All right. Good morning, everyone, and welcome to today's Think New York webinar hosted by the Empire Center for Public Policy. I'm Kyle Davis. I'm the Director of Public Affairs, and I'm thrilled that you can join us for what promises to be an insightful presentation. Think New York is our monthly webinar series where we delve into pressing issues affecting New Yorkers. Today's topic is particularly timing as we examine the challenges surrounding New York's Medicaid program and its far-reaching implications. Before I get started, I want to encourage you to engage with us by submitting questions in the chat. Bill Hammond, our Senior Fellow for Health Policy, will address them during the Q&A session at the end of the presentation. And you can just put them right at the end of or right in the Q&A section. At the Empire Center, our mission is to promote transparency, accountability, and fiscal responsibility in government. We conduct in-depth research on a wide range of topics, including taxes, healthcare, labor, energy, education, to provide citizens with the information they need to drive meaningful change. Today's presentation will explore Bill Hammond's latest report, Medicaid Overdose, the excessive growth of state-sponsored healthcare coverage in New York, and Bill will take us through the findings of that report. Bill brings unparalleled level of expertise to this discussion with nearly 3 decades of journalism experience and a deep focus on New York's healthcare industry. His insights are second to none. Since joining the Empire Center in 2016, Bill has really established himself as a leading voice in healthcare policy analysis. So as we dive into this important topic, please remember to drop your questions in the Q&A. Bill will be addressing them at the end of the presentation. And otherwise, I will turn it over to you, Bill, if you want to share your slides, because I don't think they're up right now. We will get started.
I'll be sharing slides in a couple minutes. So, good morning. Thank you, Kyle. Thank you for everyone for being here. Today we're gonna be talking about Medicaid, some things that are going on in the Medicaid program related to enrollment. Every year we have a big discussion about spending and the Medicaid budget. I think sometimes enrollment kind of gets lost in that. I know for many years I took for granted that enrollment was there were enrollment rules and people were applying according to those rules and the state was enforcing those rules. And so if enrollment basically reflected how many people were eligible, I think there's reason to believe that that's not working the same way it used to work. And I guess the first what kind of got me going on this was noticing how high Medicaid enrollment had gotten. So about 10 years ago, 29% of the state were enrolled in Medicaid. Today, it's more like 36%, so over a third of the population. And when you add the essential plan on top of that, the essential plan, I'll talk more about what that is exactly later, but it's essentially an extension of Medicaid coverage. From the consumer's point of view, it looks a lot like Medicaid coverage. It doesn't have a premium and it has very low copays and coinsurance. So when you add that on top, our overall enrollment in Medicaid or Medicaid-like coverage is 44%. So getting close to half of the population. And in New York City, it's 60%. So 3 out of 5 residents of New York City, according to state enrollment numbers, are enrolled in either Medicaid or the essential plan. And I just think on a gut level, that seems high. We think of these programs as being safety nets for the indigent and the disabled. And I just don't think anybody's conception of indigent or poor and disabled covers 60% of the population. I think that just kind of struck me as hard to believe. And so what this analysis did was it looked at information available for the census from the Census Bureau about what numbers of people we have at different income levels and how those line up with eligibility for Medicaid. And I think it's fairly clear when you do that analysis, when you compare enrollment to the demographic data we have available, that enrollment is higher than you would expect. It's higher than you would expect based on poverty and disability in the population. And I think this is a concern, a red flag that things are going astray within the program. And this is like the most important thing New York State does. It's a program that's a matter of life and death for the people who need it most, extremely vulnerable citizens who have lifelong um, disabilities. In some cases, they're not able to certainly have limited ability to earn income that would pay for their own care, and yet they have very high costs for both medical and long-term care. And so I think it's important that we get Medicaid management right, and I think this is a sign of trouble in the Medicaid program. Um, just as a matter of level setting, it started in 1965. It's a federal state program. It provides health insurance that covers both acute medical care and long-term care. It's jointly financed by the federal and state governments, and in New York's case, there's a substantial amount of money that comes from local government, from the counties in New York City. New York, it has a matching system, so whatever the state spends, the federal government matches that amount. In New York's case, sort of officially, it's a 50-50 match. Sometimes gets to be more than 50. And New York has sort of traditionally viewed this as an opportunity to draw down as much federal aid as it can. As a result of that sort of philosophy, we have a very large and generous program compared to most other states, and the highest per capita spending of any state, per capita meaning per resident. It was expanded as part of the Affordable Care Act in 2014. New York's program didn't need to expand that much because it already almost entirely met the standards of the ACA, but there was a little adjustment in eligibility that had to make to meet the ACA requirements. And then in 2015, 2016, New York was one of only 2 states that exercised an option under the Affordable Care Act, where it could take money that would otherwise go towards tax subsidies for people buying health insurance. It took that money from the feds and it could use it to directly insure people, called a basic health program. New York's version of it is called the Essential Plan. And so that was, in effect, another expansion of Medicaid-like coverage in New York State. As I said, this is a really important program for the well-being of vulnerable residents, but also it plays this really important and kind of increasingly central role in the healthcare system, and certainly with how the state manages and finances the healthcare system. So I'm going to share my slides. So this is a comparison of New York's Medicaid enrollment with other states as a percentage of our population. If you include the Essential Plan, New York is head and shoulders above every other state. The average enrollment rate is 24%. New York is at 44%. We're 7 or 8 points higher than New Mexico. The other state that has had an essential plan all along is Minnesota. Minnesota's enrollment rate combined in Medicaid and its basic health program, which is called Minnesota Care, its combined enrollment is actually a little bit under 24%. So there's no other state that has been as aggressive in using Medicaid and other federal programs to provide premium-free taxpayer-financed health coverage. So we've had two big increases in enrollment in the last decade. The first was around the Affordable Care Act. So between 2013 and 2015, we added about 1 million enrollees. Um, about a third of that increase was people who were newly eligible. People, where the state did have to lift the eligibility limits. And as a result, people could now apply for the program. But most of the new enrollment, 70% of that new enrollment, was people who had been eligible before the Affordable Care Act. And they just, for whatever reason, they hadn't chosen to sign up. At least that's how the state explained it to the federal government. They said we have 30% are newly eligible and 70% are not newly eligible. So the idea was that people had been eligible all along. The Affordable Care Act started. There was a lot of publicity around it. There was this new mechanism called the exchange, which was like one-stop shopping for all of the available insurance options. And for at least for a short period, you had what was called the individual mandate, which was a tax penalty if you didn't sign up. And I think for all those reasons, people were finally convinced if they were eligible for Medicaid, they were convinced, okay, now is the time for me to sign up so that I don't have to worry about I can sort of help with this national effort to reduce the uninsured rate, and I can avoid paying a tax penalty in the bargain. The second big surge in enrollment, things leveled off after the first couple of years of the Affordable Care Act, but then when the pandemic hit in 2019, 2020, in 2020, there was another really big increase in enrollment. Some of that was due to people losing their jobs and their health coverage, but I think most of it was related to this federal emergency policy, which said states during the pandemic emergency, states could not take people off their Medicaid rolls, no matter, even if somebody found a new job, got health insurance, didn't need Medicaid anymore, the states were supposed to keep them on the rolls until the emergency was over to make sure to avoid disrupting coverage. I think when they enacted that policy, they thought it would be a short-term thing, but it ended up lasting for 3 years. And as a result, a lot of people kind of accumulated on the rolls who many of whom probably didn't need the coverage anymore. But during that period, enrollment went to just an unprecedented height, almost 8 million. It was about 2.5 million more than it had been before the pandemic. I'm sorry. That emergency ended in spring of 2023. And states have been going through this process of unwinding the emergency order. They are going through their roles and identifying people who are no longer eligible. So now let's look at this same chart, including the essential plan. And you can see the essential plan started in 2015. It had already picked up substantial enrollment in 2016. And it also grew during the pandemic. And one thing that's happening during the unwind is that people who are leaving Medicaid are going to the essential plan. So the essential plan is having a kind of surge in enrollment. The state also increased the eligibility limit for the essential plan. And so at any rate, you can see that enrollment is currently it's currently a lot higher than it was before the pandemic, especially when you factor in the essential plan. And according to the projections from the state budget division and the health department, it's going to continue to be a lot higher than it was before the pandemic. So I'm going to be referring to poverty levels and percentages of poverty levels a lot in the next segment of this talk. And so I thought I wanted to sort of explain where those end up. These are federal poverty levels for 2024. So like for a family of four, the poverty level is 31,200. The standard cutoff for Medicaid is 138% of the poverty level, so a little bit higher than that, 43,000 for a family of four. The cutoff for the essential plan for the first several years of its existence was 200% of poverty, which is 62,000 for a family of four. And now, as of April, it is 250% of poverty, which is 78,000 for a family of four. I bring all this up to point out that the median wage in New York State is $78,620, which means half of people in the tax system, half of people in the state are making 70 less than that, and half of them are making more than that. My point is to say that if you're providing safety net insurance to people up to $78,000 for a family of four, you're starting to get close to anybody's definition of the middle of the income range. So while enrollment was growing, here's what was happening to the poverty rate. The Census Bureau, as part of its attempt to track what's going on with health insurance coverage, it tracks for each state and each county, it tracks how many people are living at different income levels tied to the Affordable Care Act. So one of those income levels is 138% of poverty. The Affordable Care Act wanted all states to lift their eligibility limit to 138%. It turned out that because of a Supreme Court ruling, that became optional. Most states chose to do the expansion. New York was one of them. And so that became the kind of new standard for Medicaid, was 138% of poverty. And you can see the number of people living at that level was declining. So that's kind of a positive trend. It was almost 4 million a decade ago, and it's down to about 3 million, just over 3 million as of 2022. So let's compare. This is the population under 138%. And here is the Medicaid enrollment. And I guess I should have clarified, the Census Bureau does this. When it does this analysis, it omits people over 65 because they all have Medicare. So this chart is non-elderly. I guess my point here, though, is that while poverty was going down, enrollment continued to go up. And as a result, the two numbers were pretty close together in 2013, before the Affordable Care Act, and they've got steadily farther apart in the years since. Even before the pandemic, the Medicaid enrollment number was almost twice the population under 138% of poverty. And it got, by 2022, the numbers were even farther apart. That was partly, like I say, it was partly because of the pandemic emergency, but it appears, based on projected enrollment figures, that we're going to continue to have a huge gap between enrollment and the eligible population. Now here's a second analysis. This is the population under 200% of poverty, which was kind of the essential plan, the combined essential plan and Medicaid population. It also was declining over the last decade, with a bump during the pandemic. And this is the population that's on the combined programs. This is population wide. It's no longer omitting the elderly. And you can see that there's a substantial disparity. In fact, Medicaid alone covers more people than living under 200% of poverty. And the essential plan is on top of that. So I wanted to sort of just to sort of try to clarify things. This is these are all numbers for 2022, and they're all ages. Population under 138% of poverty is about just over 3 million people. Then there's another million or so who are in the next income range up to the previous cutoff for the essential plan. And this is the population that's under the current cutoff for the essential plan. So it's 5.5 million people roughly as of 2022. And here's Medicaid enrollment. And Medicaid enrollment alone is substantially higher than the entire population uh, eligible for the essential plan as according to the Census Bureau. And here's the essential plan on top of that. And so this is where I come up with my estimate that there are 3 million people who are enrolled in one of these safety net health plans who appear to be above the income limits for those programs. Now, I guess there's caveats are in order here. We're taking data from two different data sets, although the Census Bureau is designed this data to be used for analyzing insurance coverage. They use a slightly different method for counting income. It's a survey. They're asking people to say what their total income was in the previous year. The state disregards certain forms of income when it's considering Medicaid eligibility. There are also some groups of people who are eligible for Medicaid outside of the normal income limits. So, for example, pregnant women or people with AIDS, in some cases, people with disabilities can buy into the program, and the income limits are different. So there's room for some, you wouldn't expect the enrollment to be exactly the same as the population that has the right incomes. I don't think any of those factors come close to explaining a gap as large as 3 million. Another thing that's happened during this growth is that the demographics of Medicaid itself have changed pretty significantly. The number of elderly and disabled people in the program as a share of the total dropped from almost a quarter of the population in 2013. They're now down to 18%, so less than a fifth of the population in 2023. The biggest growth was in the category of non-disabled adults. They went from representing 38% to 49%. And by the way, 49% of a much larger number. In 2023, Medicaid enrollment was 7.8 million. It was pretty much close to its peak. And so the program is now dominated by people without disabilities. And as we've seen, many of them are going to be above the federal definition of poverty and even the federal, the official income limits for these programs. So I tried to think through how this could have, what explains this big run up in enrollment. I mean, obviously the ACA expansion played a role. There was a policy change that New York implemented in the early years of the ACA, where they said we're going to have continuous enrollment for adults. So once you're in, if you apply at a time when your income is low and you qualify, you're in for at least 12 months. There, even if you get a job during that ensuing 12 months, and even if you get some other kind of insurance, we're going to keep you on the rolls just to make sure there's no disruption in your coverage. And so that would lead to some people who are over the income limits being enrolled, at least for a short period. I should explain that I don't think that might explain why there would be some overage. What I don't think it explains is why that overage keeps getting larger. It's gotten larger every year since the Affordable Care Act took effect. And it's now, like I say, 3 million people above the income limits. I think that number, that continuous enrollment explains probably part of the excess, but I don't think it explains all of it. I mentioned before that there are categories of people who can be eligible even if their incomes are above the normal limit. So for If people living with AIDS can qualify for Medicaid up to 185% of poverty, pregnant women and infants can go up to 223%, and working people with disabilities can buy into Medicaid uh, currently up to 250% of poverty, and there's a proposal from the Hochul administration that would dramatically increase that. But those numbers, the numbers of people in those exceptional categories are in the tens of thousands, or even in maybe a few hundred thousand. Again, there's not enough of them to explain a $3 million person disparity. One area that I do think helps to account for the disparity is what's going on in home care, where we've had just a massive run up. Overall enrollment in managed long-term care, which is mostly home care, is up 85% since 2016. And CDPAP, the Consumer Directed Personal Assistance Program, by itself is up 1,200% since 2016. We're talking about an increase, you know, we're getting close to 1 million people who are qualifying for those services. It's somewhere between 600 and 800,000. I believe. It's like we don't have good numbers on that, but the so that might explain a substantial chunk of the Medicaid overage I'm talking about. Because another way that you can get Medicaid with higher income is through estate planning. You can um, you can use various legal maneuvers to protect your assets from scrutiny by the Medicaid program, and protect some of your income. You can put it in a trust, and Medicaid will disregard. Um, if you do it properly, you can qualify for Medicaid even though you have substantial wealth. So why should we care about this excess? I mean, just on one level, I think, like I say, it's a sign that the management of the program is gone awry somehow. That it's erring too much on the side of letting people in when it should be, according to its own rules, it should be excluding people. The obvious one obvious impact of this is on the budget. Uh, Even if you assume that the 3 million people are sort of the lowest cost type of enrollees, non-disabled adults and children, they would still probably be costing the system about $20 billion a year. Um, and with the feds picking up half and the state picking up half. State Medicaid spending has been really rapidly rising in recent years. It's up 53% over the past 5 years. I don't think all of that is driven by enrollment, but certainly enrollment is playing a role. And Medicaid is now consuming 28% of the state budget. It's never been that high. 20% of state operating funds. It's sort of on track to surpass school aid. It's the most expensive thing that the state does. The increase in Medicaid probably played a role in reducing our uninsured rate. It's now down to about 5%. But the thing is, over that past decade, the number of uninsured people came down by 1.2 million, but the number of people on Medicaid in the essential plan went up by 3.7 million. So some of those people who are now enrolled would have been uninsured, but most of them would have had some other kind of insurance. At least that's what it looks like. If you add almost 4 million people to the rolls, and your uninsured population only goes down by a third of that, you're targeting people. You're what's called crowding out private insurance. This is particularly acute in the subset of the insurance market that's called Obamacare, like the so-called Obamacare plans, where you go to the exchange as an individual, you don't have employer-sponsored insurance, and you buy what's called a qualified health plan through the exchange. And in many cases, those are subsidized by tax credits and other subsidies. The range of people who are eligible for that type of insurance and that type of subsidy is just above Medicaid, 138% of poverty, up to 400% of poverty. But in New York, half of that range is covered by the essential plan. And essential plan enrollment has is now about 1.5 million people. Qualified health plans are only about 250,000 people. Um, when they passed the Affordable Care Act, they kind of envisioned that these two things would work together. Medicaid expansion would cover some people, and subsidized insurance would cover other people. It'd be like 1/3, 2/3. 1/3 Medicaid, 2/3 essential plan, or I'm sorry, 2/3 subsidized insurance. As time went on, the Medicaid numbers were higher than expected. The qualified health plans were a little bit lower, so it was more like a 50-50 split. But in New York, it's a 15-to-1 split. We've had 15 people sign up for state-sponsored safety net plans versus for every one person who signed up for a qualified health plan. That has the effect, you're taking people out of the risk pool for those subsidized plans. When you take those people out of the risk pool, and in fact, you're taking people who tend to be younger and healthier just by the nature of the essential plan. It's targeting people who are they're employed, but they're at the beginning of their careers and they have relatively low income. So the state has talked about this in some of their waiver applications. They acknowledge that the impact on the insurance market just outside the essential plan is going to drive up premiums and result in people dropping coverage. As part of the most recent waiver, in fact, they took some of the money that was going to the insurance plans and they kind of earmarked it and they said, you should use this money to offset the premium increases that this waiver is going to cause. Now it's a kind of interesting attempt to work around that problem, but it's also an acknowledgement that the essential plan is in fact cannibalizing the commercial insurance market, and it's causing commercial insurance to be more expensive than it otherwise would be. A final impact that I would bring up, and in a ways it's the most important one, is that this enrollment increases led to mission creep. Medicaid started out being a safety net health plan for the indigent and disabled. I don't think we can describe it that way anymore because the disabled are a shrinking minority of the enrollment population, and more and more of its enrollees could not be described as indigent. Many of them have incomes well above the poverty level, and they have jobs. So that those less needy enrollees and the people who are providing medical care for them are increasingly the dominant factor in terms of managing Medicaid. And as a result, you have the really the most vulnerable people on Medicaid are kind of competing for resources with the less vulnerable. And I don't mean this to be like a judgment thing about who deserves coverage and who doesn't deserve coverage. I'm just saying this is like we set up rules for this program. We said this is the target demographic we intended to cover, and we're going way beyond that target demographic. And as a result, we're diverting resources and attention from the people who we intended for this program to help first. My recommendations are that to start, the state needs to investigate exactly what's going on. I mean, I've tried to sketch out some of the factors, but I think ultimately it comes down to policies and procedures on a granular level. As the state looks at each applicant, it's making a judgment about whether to admit that person to the essential plan or to Medicaid. And there's something in that process that's seemingly allowing millions of people in who don't fit the template of either program. I think our goal should be to rebalance our insurance system to to downsize the taxpayer funded part of it and upsize the commercial part of it. Um, that would require um, making the commercial health insurance more affordable, more accessible. That would require, um, for example, rolling back the taxes that the state imposes on health insurance, which they use to finance Medicaid, but which make commercial insurance unnecessarily expensive. It would be being more careful about how you regulate insurance to avoid adding costs that are going to make it less affordable and less accessible. It would also mean rethinking the essential plan. I mentioned before that Minnesota has an essential plan, and yet it's the size of its taxpayer subsidized insurance market is relatively small. And so we could run the essential plan in a way that actually targets the population, the income range that it's supposed to target instead of apparently expanding way beyond that. And then all of these efforts would result in savings for the Medicaid program. If it's covering fewer people, you're going to save money, and you can reinvest that savings into the indigent and disabled populations that were its original purpose. So that's what I put in my paper. That's what I wanted to talk about today. Um, I'd be happy to take any questions people might have.